Greetings. Thank you for joining us for this installment of our AFI Innovations in Public Health series. I'm your host, Michael Thompson. I'm an associate professor of public health sciences here at UNC Charlotte and associate director of AFI, the Academy for Population Health Innovation. AFI is the collaboration between Mecklenburg County Public Health and UNC Charlotte, where we seek to bring practitioners and scholars together to share best practices, discuss cutting-edge innovations, and find common ground as we pursue our shared mission of improving and assuring the public's health. My co-host today is Carrie Birch. Carrie?
Thank you, Michael. Good morning, everybody. I'm Carrie Birch with the Office of Innovation and Strategy with Mecklenburg County Public Health. As always, I'm excited to see so many folks joining us for today's session. A little bit about the program in this series in general. We envision these as virtual sessions to provide opportunities to engage and interact outside of our daily silos and learn about some of the great work in our community. To encourage dialogue through this session, we have enabled the participant list and the private message functions. So we encourage you to look through the list and to reach out to someone you haven't connected with in a while, or feel free to introduce yourself to someone new. Later in the program, of course, you'll have a chance to give feedback using a Qualtrics survey that we'll post the link to in the group chat. So keep your eye out for that.
And we will be recording these sessions to post to our AFI website, afiinnovation.org, so that you and those unable to join us today live, because we know it's a hectic time of the year, so you can revisit us as often as you like. And while you're there, you can check out our prior seminar library and see how all the other ways that AFI is supporting public health in Mecklenburg. Today's session, we focus on an award-winning program, a partnership between our local police force and child mental health experts that seek to mitigate the adverse effects of children exposed to violence and other traumas. I'm pleased to note that this session is worth one contact hour of ACHE, CHES, CPH, or social work. ACHE and CPH are self-reported. To receive social work contact hour or CHES CEU credit, you will need to make sure that you complete the survey that Carrie mentioned, making sure you check the box for CEUs and continue to complete the follow-up CEU questions.
All right, we're going to jump right into it. Our panelists today are Stacey Butler and Travis Hales. Stacey is a licensed clinical social worker with Mecklenburg County Public Health and directs the department's trauma and justice partnerships. Travis is an assistant professor in the School of Social Work at UNC Charlotte, where he directs the MSW program. I believe Stacey is going to get us started today. So Stacey, it's all yours.
Thank you so much. This is really I'm just humbled to have this opportunity to talk about a program that I think is likely one of the smallest yet biggest programs you've never heard of. Many of you may have never heard of. So this is a wonderful opportunity. And when I was looking through the folks as people were coming on, I happened to see a police major in attendance who is someone who was taking me out to visit families in the very early days of my work with this program. So it's wonderful that we've got such a great group of professionals on the call, and I really appreciate the opportunity. I have been involved with CDCP now, Child Development Community Policing, since 2001. And I'll give you a little bit of my own history with the program when I'm also talking about the program history later in our slides. But we're going to start off by just sort of level setting and talking about what we mean by child trauma. So for our purposes today, because I think in our national lexicon, trauma now means a lot of different things. and is used, the word is sort of thrown around in a lot of different contexts. But what we're talking about today is acute trauma. We're talking about a very identifiable set of experiences and reactions that a child or a person may suffer following a significant event. And those events would be things that really threaten life or limb for an individual, or especially in when we're talking about children, the life or limb of their immediate caregiver or household member, people that they are very close to and that they depend on for everything that they need, including their own survival, right? So exposure to violence, when we talk with police officers in our trainings, we have to differentiate between what makes someone potentially a good witness in a crime, and what would make someone a trauma victim or having been exposed to a potentially traumatic event, because those two things are not always the same, especially when we're talking about very young children. Trauma is multisensory. It's experienced by people with all 5 of our senses. So it's things that are incredibly threatening, that we may see, hear, we may smell, we may touch, right? Or even taste. So those things, hearing about it, hearing about the aftermath. And I also want to make the distinction between, something that you may turn on the nightly news and or read about and think that this is a very upsetting situation, is we're talking about something a little bit different than that today. We're talking about, for example, a child who may see the aftermath of a horrible domestic violence incident. So overturned furniture and blood on the floor, for example, and their brain may fill in, the empty spaces of what happened to my mommy, right? And I should also preface this with some of the things that we may be talking about today might be, upsetting for some folks, and you're certainly not going to offend me or offend Travis if you decide to take a step back and take a break or leave the webinar as well. So I fully understand. So we know that that when we are born with fully functioning online threat assessment centers in our brains. So we are not born necessarily, with all of the skills and abilities that we're going to have later in life, especially when it comes to, language or motor skills. But we are born with a fully functioning alarm center, threat assessment center, and the ability of our nervous systems to react to threat. So infants, toddlers, preschoolers are just as capable of perceiving threat and reacting to threat as adults are. Those reactions just look a little different behaviorally to us, but chemically, they are identical inside the human brain. So Travis, we'll move on. Thanks. So this is an analogy that we use in training police officers a lot, because the idea of why do I refer an infant or a toddler is sometimes a new concept for adult learners, right? And for the parents that we're serving in our program, it's very comforting for adults, I think, often to think, my child is 6 months old, they won't remember this, so they're fine, right? Or my 2-year-old is playing with trucks on the floor, so they must be okay. And we like to talk with folks about the fact that if you think about a tree, the example of a tree, a very young, tiny sapling in the midst of, say, a hurricane is going to experience that hurricane very differently than a big, huge, strong oak tree. And trauma can be very similar. The process that begins in the brain spreads into the nervous system, out into all the other parts of our bodies, impacts our organs and our other functions, can really disrupt typical development the younger that we are, and have different impacts and potentially bigger, lifelong impacts the earlier that those things happen. The older that we are, the greater our capacity to express what's happening, to seek out support, to get support from a lot of different places. School-age children may have supportive teachers or coaches or, other people in their lives that very young children may not have. And if your parent is themselves experiencing significant trauma, their capacity to respond well to their own children, may not be what it would have been had they not also experienced trauma. So a big portion of our program, and we'll talk about that as well, is the partnership that our clinicians have with officers, our ability to provide tandem physical and psychological safety services, as well as coaching for parents and assistance with service linkages that we think really affords the families that we serve a special and unique opportunity for stabilization after some of our community's most horrific violent incidents. Thanks. So it's really, I think, interesting that as the concept of ACEs, or adverse childhood experiences, was first really being looked at and studied in the United States. Out on the West Coast, there was the earliest beginnings of this effort to respond better to children impacted by violence happening on the East Coast at the same time, without knowledge of one another. I think a lot of people on the call have probably read about ACEs, know about its early, the early studies that started with a Dr. Folletti out in California, who was running a weight loss clinic and had a lot of successful clients who later were, were gaining a lot of the weight back and having health struggles as a result. And in trying to get to the root of that, he identified similarities amongst a lot of those patients that showed up in early childhood adversities, early childhood traumas that were of a similar nature for many of them. And then Kaiser Permanente, big insurance company, took it a step further and said, we're going to look into this and study this on a massive scale with thousands of our insured. And sure enough, the same patterns emerged. And from those original 10 ACEs that were studied, that included things like child physical abuse and sexual abuse and divorce of parents and substance abuse in the family and having a caregiver jailed or incarcerated. We have since learned that there are a number of other significant stressors that are to be included, including racism, bullying, being homeless as a child. So the original study, the folks looking at that coined this term stepwise fashion with regard to the risk that rose as the ACE score increased. So the closer someone got to that top score of 10, the greater their risk went up. for a surprising myriad of issues. So not just mental health struggles or struggles educationally or in the legal system, but a whole host of the number one health problems that we face as a nation: heart disease and diabetes and a whole variety of other things. So there's a bit of a chicken and an egg kind of question that's still out there with regard to, which health issues might be caused from, chronic stress and cortisol and adrenaline and norepinephrine just sort of working its way through the blood system and impacting organs and all of these things and inflammation, and then the psychological impact and the behaviors that someone might be using in an attempt to try and maybe reduce their suffering and their pain. And I think that either way, I think we're looking honestly at both things, and they are both related to our overall health. And this idea of mental health and physical health being two different things has always been a problem for me, because our brains are in our heads connected to the rest of our body. So, this feedback loop that we're talking about, where everything is connected. So in looking at what to do about that, because the ACE study was put out and the issues were identified, and everyone's question then is, what now? And in looking at that, really the identified anecdote is good, solid relationships, good, consistent care, the best supportive possible responses post-trauma, and this idea that even with high ACE scores, that people can succeed, they can be healthy, they can be well, they can be successful, and what we need to do to provide that to everyone. So thank you. So just a little bit of history in where our program came from. So in 1991, and I love this part because everyone assumes that this program grew out of mental health professionals trying to help police officers do a better job in the field with kids, and the opposite is true. This program was the brainchild of a police chief in New Haven, Connecticut, who reached out to the Yale Child Studies Center, some of the nation's foremost experts in children's mental health, and said, we have to do something for these kids at these scenes that my officers are responding to. And Yale is literally blocks away, literally behind their IV covered walls. And so a psychologist by the name of Stephen Marins, he had a master's in social work and then went on to get a PhD, similar to someone else you'll hear from in a few minutes. But he started getting into police cars and seeing what it was that the police were doing and responding to, and tried to really follow their lead in developing, what later has, I think, become best practice responses for immediate acute trauma. So a little bit about that. So those folks up at Yale started out with a pager back in 1991, and they committed to immediately, going out with officers and responding to kids, and then offering every single one of those families an opportunity to come into the Yale Clinic for follow-up care. Right, for free. One of the nation's, foremost child trauma clinics now. A wonderful option. Here, when we looked at bringing this model to Charlotte, that option, we had no centralized child trauma clinic. We had really no ability to provide a centralized service. So we'll talk a little bit more on some later slides, but we wanted to respond better to kids in our community, but we had to pivot the original model to create something that was viable and was going to meet the needs of all of our children here. So in 1996, the Office of Juvenile Justice and Delinquency Prevention started offering funding for interested communities to go up to Yale and spend time with both the clinical staff and the police officers who were doing this work, and find out about the strategies, find out about the implementation, how they were able to do that, do some ride-alongs with their staff, and observe in real time how the work was happening. So there were some folks from CMPD and from Mecklenburg County who were able to do that and bring the project back. And in the late 90s here, really started very, very small in a pilot in Metro Division, which at that time was called David 2 for CMPD. And it was the mileage-wise smallest division. It was 5 square miles of Charlotte. And it was also the highest crime, where the highest numbers of families impacted by significant violent crime lived. So just to give you an idea of our growth, so in 2000, 204 families were served. In between 2000 and 2001, the program expanded from 1 division slowly into 4 police divisions, and brought on 2 full-time clinicians to serve those 4 police divisions. And I had the incredible good fortune of being one of those clinicians selected back in 2001. So I wasn't there in the very, very early start of the program, but I've been here a good long while. So we slowly over time and with mutual support from both the county and the city, we're able to fully expand into all of CMPD's now 13 police divisions by 2016. And I want to state that mutual support is a really big deal, because the county is providing our clinical staff, and the city is offering up their police officers to train in this work and to do this work alongside our clinicians. This is not a refer and walk away program for the police officers. This is very much a shared program. So they are really sharing in-kind support and financial support of the program, 50-50, which is really, I think, kind of a rare thing nationally, to have government entities with different funding doing such a wonderful job of sharing a mission and carrying that out, and having something be so successful and long lasting. So we have expanded into our Northtown police departments of Huntersville, Davidson, and Cornelius, and just went live in Pineville. So that's really exciting. We've got our sights set on Matthews and Mint Hill. The interim police chief in Matthews is very, very excited. He's a retired CMPD officer as well, and he's very thrilled to have this coming his way in Matthews, and so are we. You can see by our numbers, there is just an unprecedented amount of families, and that's a family count and a children count there at the bottom of the screen, that we're currently serving with 17 full-time clinicians. So our clinicians are very, very busy, and I think, honestly, I think they're some of the best, if not the best, and hardest working mental health professionals in our community. So A little bit about pivoting from that Yale model and our inability to have 100% fidelity. So anyone who lives here knows what our sprawl is like and our growth, and knows that we've got folks living from one lake to the other and everywhere in between. We've got families with pretty good access to public transportation, and we have a lot of families with really still, unfortunately, poor access to public transportation. We have a significant disparity in our community when it comes to economics and a lot of other factors that really caused us to make some big changes early on. And if we were going to provide an equitable service, an equitable alternative to a centralized trauma clinic, we had to become the trauma clinic. And I want to give due credit to the Charlotte Mecklenburg Police Department here, because without them, that could never have been done. Some of their leadership really dug their heels in early on and said, we are doing this. Our officers are doing this 24/7, 365. So we have clinicians who are on call all the time. They're on call Christmas and 4th of July. They're always on call. And if the police are at work, we've got clinicians available. And it really is an amazing thing. We have police officers who have committed to partnering with our clinicians. So if it's a homicide scene, for example, those are very chaotic. There's a lot going on, a lot that has to go on. People are doing forensics work and people are securing the scene, and all of these things are happening. We will have at least one officer who commits to being with our clinician in a team whose job is just to attend to the children who are there as best as they can. They are not, taking notes. They are not, working on the report. They are not standing by the tape or talking to the media. They are paying attention to the kids, and they are working with us and doing their piece to provide immediate safety response. And we believe that two-part intervention, that our ability to assess for earliest emerging trauma symptoms and to work with an officer who is fully dedicated to that child and that family, is the intervention and really is what allows families to begin to feel safe again, to start to feel grounded, to start to connect to the here and now, and really, begin to take a little bit of a break, a little bit of a brain break that is needed if we are going to really prevent the onset of significant symptoms, or really break that potential feedback loop up that could lead to all of that, the myriad of potential poor outcomes later on. So this is just a quick snapshot. These are not all of the reasons for referral for us in our 22 fiscal year, but these are some of them, and certainly some of the most concerning ones that we had. But you can sort of see, I think we hear a lot about the homicides. Unfortunately, we don't often hear about who else may have been there and who else may have been impacted by them. But then a lot of these other things we never hear about. The serious assaults that thankfully no one was killed. The other assaults like domestic violence, which studies have shown growing up in a home where there is regular domestic violence impacts the brain in the same way as growing up in a war zone, right? So we are no less worried about those children than we are the children present at a homicide scene, for example. So the evaluation that we use, our screening tools, the resources that we're offering families, the service linkages and responses are going to be the same. And we're going to, put forth our best efforts to engage all of our families and do what we can to meet their needs, regardless of the type of violence that they may have experienced. And I will say another thing, unfortunately, many of the families that we serve are repeat customers of ours. So these may not be independent referrals. So a child who is present for a domestic violence incident, we may see them later in the year. There may be a shooting into their home or a terrible, accident when they're getting off the school bus, right? So we may encounter some of those families several times in a year or several times throughout a child's childhood. So I talked about how we're available 24/7. And our services really are designed, like I said, in tandem to address immediate safety and to screen and assess for those earliest emerging symptoms. We really we don't just, I guess the traditional mental health model, right, is someone is suffering. They may be suffering for a very long time. They reach out to a service provider. They come in for an assessment. You do the assessment. Perhaps you then have them back for developing a treatment plan, and then you have them back maybe the next week and start working towards the plan. That's not our model at all. We immediately start looking at, okay, what's going on physiologically? What can we see? And if it's at the 0 to 12-hour point, we're looking at those really early, sometimes very subtle indicators that some significant stress is happening and we need to do something about it. At the 12-hour point to the 29-day point, so in the pre-diagnostic phase, which is where we work, we're in that secondary prevention place, we're looking at what those earliest emerging symptoms are, and then providing immediate intervention. So we're intervening as soon as that screening is happening, and then we are can we maybe have
Stacey, you're on mute now.
Sorry, I don't know what I said that you heard or didn't hear, but at that 12 to 29-day point, that pre-diagnostic point, we are providing still immediate interventions as well as parent coaching, and then checking back in to find out what the symptoms are looking like, and coming back out and providing a second or third opportunity to intervene with those symptoms, with the hope of complete symptom mitigation. If there are still some lingering symptoms, or we identify an ongoing longer term issue like chronic domestic violence, then we are often helping link the family with referrals for their child, linking the family with referrals for adults. And then depending on what kind of issue it is, if it's in particular a child sexual abuse investigation, we're working with Pat's Place so that they are taking the lead, and we are coming back in on the back end only if they have been unsuccessful in engaging a family around the therapeutic needs of their child. So let's see, we talked about how we are the intervention, our clinicians and our officers. We really believe that no child should ever have to wait for the absolute best possible trauma-informed response and coordinated care. We were thrilled a couple months ago when GlaxoSmithKline selected us for an award that is in support of our training efforts for our clinical team, because we really want our team to have really the absolute best and state-of-the-art therapeutic intervention training opportunities, so that they can provide that to every child in our community free of charge, because we know that this work is our best opportunity to prevent lifelong issues. And honestly, it's a crime prevention piece too. That ACE's response is really where our public health efforts and law enforcement efforts intersect, because we want to keep people out of hospitals. We want to keep people out of jails. We want to, we want everyone to have the best possible life outcomes. So Travis is going to talk to you a little bit mostly about, I think, our ATQ, but just to give you an idea of what we're using, and I covered some of this, but when we are successful in engaging a family around the trauma experience and needs of their children, we will then offer a screening for their children. And depending on the experience of the child and the timing of our contact with the family, we're either offering that 0 to 11 hour evaluation with those earliest, I'll give you a snapshot of what that looks like, those earliest possible indicators of stress, or we're looking at the earliest emerging symptoms from that 12-hour to 29-day point. And then when we're looking at polyvictimization, chronic stress, a lot of times when there isn't an acute trauma reason for referral, but maybe a police officer refers, say, a runaway and says, this child is a chronic runaway. I have a lot of concerns. I think there's a lot going on here under the surface. We may use that trauma history questionnaire and try and get a better idea of what all the factors might be for that child, so that we can make the best possible referral that's as well matched to their needs as we can. So this is just a snapshot of that autonomic nervous system screener. I think I've got if you hit it one more time, Travis, I think there we go. So, this gives you an idea of the pupil dilation and heart rate, and, some of the, digestive or somatic issues, stomach pain, and different things that we use to really get a handle on the fight, flight, or freeze that occurs in a typical acute trauma response. And do we think the child is in fight or flight, or do we think the child is in freeze? That can look very different for infants than for, say, 12-year-olds. And there are different interventions that can be effective in fight or flight versus freeze. So we don't want to apply the same interventions across the board for every child. We want it to be very specific and effective. And so this is our way of just kind of tracking for ourselves, what did we see in each child, and at the end of our intervention, was that symptom still present or not? And we may do this and then 2 days later do our acute trauma questionnaire, so we can look at, okay, we saw this early emerging issue. Are there symptoms starting to emerge at this point or not? So what do we need to do about that?
Great. Thank you so much, Stacey. And we are going to be pivoting now to the evaluation processes that have been taking place over the past several years. But again, I'm Travis Hales. I got connected with AFI, and Stacey around 2018, 2019. and definitely been grateful for the partnership and the opportunity to work together and do some of the evaluative work that Stacey has been wanting. So what we started out with was a process evaluation. So this was primarily qualitative methodology. We did semi-structured interviews with CDCP leadership, management, and frontline staff from both the health department and the CMPD side. That was the first step, took a couple of years, but we did wrap up those analyses and developed a technical report of the findings. We'll go over a couple of those today. What we're currently working on is looking at some of the assessments that CDCP uses and checking their reliability as well as their validity. And lastly, what we hope to accomplish is an outcome evaluation where we're analyzing a combination of administrative assessment and outcome data. So to go over each of the three approaches for the aim and method of the process evaluation, really what we want to do is interview key stakeholders and inquire into their perceptions of the program's purpose, its policies, procedures, and practices, its impacts, potential areas for growth, and diverse benefits. So in order to accomplish this, we did do semi-structured interviews. Stacey and I worked together with a couple other key stakeholders to develop the interview guide. And then we interviewed a total of 21 stakeholders. There were 14 CDCP personnel, as well as officers, and then 7 individuals in leadership from both the health department and CMPD. Once we conducted the interviews, they lasted typically, 30 to 45 minutes apiece. We did the transcriptions, and actually I did see that Jessica Willard is on the call. She was a graduate assistant during this time and helped me out with the coding. So we had 2 coders go through and code all the data and come to inter-rater agreement and then develop some themes based on the questions that we asked. So this process was really important for me just to come in and get some exposure to what the CDCP program is and how it's perceived by the key stakeholders there. And really, it's been helpful for me to leverage these data to think through from a quantitative perspective, what types of questions should we ask, and really to help guide that outcome evaluation. So some of the key findings from the process evaluation from the clinicians and supervisors, it was pretty unanimous that there was a very supportive culture and climate. There's a very strong emphasis from leadership, really starting with Stacey, but then all the way down for clinicians to practice self-care. It really is a hallmark of trauma-informed organizations to really prioritize self-care practices for all staff members. The clinicians were really grateful and appreciative of the collaborative relationship that they had, a lot of times with specific officers, but sometimes also with departments within CMPD. Clinicians definitely felt like they were embraced by CMPD and welcomed in. One of the key aspects of the program that both clinicians and CMPD officers and administrators said was that the immediate response is critical. Stacey talked about this throughout the theory and underlying philosophy of the program, but really having that immediate clinical response really supported engagement. And another key benefit of the program that was shared amongst clinicians as well as CMPD and leadership was that going out into the community and doing that immediate response really reduced barriers that families typically have in terms of getting access to mental health services, even things like screens, assessments. Those are critical. So the program being what it is and going out into the community was noted as a huge pivotal important aspect of the program. So really, we had a couple questions in there as well that we wanted to guide what the outcome evaluation would look like. So we asked everyone we interviewed how they would define CDCP's outcomes. And the majority of folks said it was about assessment. So doing that initial trauma assessment, doing brief intervention, and the intervention, it looks fairly similar, but it's also very unique to what comes up in the assessment. what the referral type is. So there are a number of different like brief interventions that do occur, but sometimes it really is just support to the families in whatever form that looks like based on the incident. And then also referral based on the assessment. Referral is a key outcome if the individuals need more than a brief intervention. And one of the biggest outcomes, and from an evaluation viewpoint, it definitely also is one of the hardest things to really assess, but it is the prevention of the development of trauma. That's really the impetus of the program, is to try and catch this early to prevent some of those deleterious outcomes that were found in the ACE study. So definitely prevention is really a big hallmark of the program. From the CMPD side, some of the key things that came out is that any officers that have worked with the CDCP program or are familiar with it, they all typically use universal precautions. So whenever they arrive to a scene that could potentially have any traumatic components to it, and there is a child present, they're automatically thinking referral to the CDCP program. They definitely noted a lot of respect and camaraderie that they have with clinicians. It's essentially how CMPD would word a collaborative relationship. So they felt like they worked really, really well with clinicians and appreciated the clinicians' perspectives and being on board. Again, they also noted that the immediate response support was a critical outcome of the program. They really appreciated aspects of connecting families and the communities to needed resources and the roles and the help that they could play in doing that. CMPD personnel also really appreciated having access to mental health professionals because they learned a lot from the clinicians. They continue to do. It increases their awareness, their knowledge of mental health in general, where a lot of times they aren't necessarily getting this type of training either in school or on the job. And one of the critical things too is that it really started to change officers' approach to policing by understanding some of the behavioral and mental health aspects of human behavior. So in terms of currently what we're looking at, we are focusing a bit on the ATQ, the Acute Trauma Questionnaire, for the reliability and validity. It's the most commonly used screen in the CDCP program. And the first step was that really Stacey and I, and Stacey working with her data team to be able to pull some data, de-identify it, and share it with me so that we could do some reliability and validity analysis. So we have looked at the Cronbach Alpha. It's a form of reliability or internal consistency of a scale. And typically what this is looking at is if the items in the scale are all measuring a single construct like acute trauma, there should be a decent amount of shared variance across the items in the scale. That shared variance essentially is what the Cronbach Alpha reliability tests are looking at. And we do typically want to see these around 0.7. So if the Cronbach Alpha is around 0.7, that's perfect. If it's too high, oftentimes that means that there are a lot of duplicate items that really are measuring the exact same thing. So we really want to see these around 0.7 in all three versions, the infant, preschool, and child. ATQs were in that good reliability range. So basically what we're working on right now is we're going to do a split sample exploratory factor analysis and confirmatory factor analysis for each version of the ATQ. And this will give us a lot of really good insights into the validity of the three versions of this measure. So basically what we're looking at right now are the inter-item correlation matrices to see which items in the scales are more correlated with one another, to try and see if there are any underlying factors or if it is a multi-dimensional construct, the ATQ. And basically in layman's terms, that just means are there different aspects of acute trauma that could potentially be like subscales within the scale. And Stacey and I are talking about looking at those from like an a priori theoretical perspective, but we're also going to use a combination of that and a data-driven approach based on the inter-item correlation matrix. And lastly, all this is gearing up to do quantitative evaluation and outcome evaluation. Again, I learned a lot from my communications with Stacey about the program, but then also with her staff and the CMPD staff around what are the key intervention processes, what are the key outcomes. And really, Stacey and I are working together to think through what are some of the evaluation questions that we want to answer, that we can answer based on the data that is available to us. So in terms of the initial incident, we do have access to the reason for the referral, if contact, and the nature of the contact that was made with the family, but then also the response and what the response looked like. In terms of the intervention, this is where it does get a little bit muddy because a lot of the intervention components are also outcomes. So things like assessment, like assessing the family is a primary outcome. It's also a primary intervention that CDCP delivers. So we have the various assessments that the clients receive, and then we have the various services, be that a brief trauma intervention, psychoeducation to the parents in terms of what to look for in the kids if things start to develop. But then also the service can be support. I heard a lot of really great stories from CMPD, from the officers and from the clinicians around the various supports that they've offered. And sometimes it really is just sitting down with a child and being there if their parent is hospitalized or just experienced a very traumatic accident. So really, trying to quantify support could get a little bit difficult, but we're working through all this stuff here in terms of the outcome evaluation. And then another critical piece of the intervention is also referral. So it's based on assessment, and there are a number of different agencies that CDCP has relationships with to where they make referrals to. They're a combination of therapeutic and non-therapeutic agencies out in the community. So some of the key outcomes that we definitely want to look at are PTSD prevention. Again, very difficult to quantify, but we're working on it primarily through looking at symptom reduction. So there are a number of clients that receive the ATQ initially, but then again, at some point in the 29-day period that they might be active clients, for lack of a better word, with CDCP. So in all those cases, we'll definitely look at what was the initial ATQ score, what was done in the interim in terms of service referral, and then at some point later within that 30-day range, was there a decrease in those symptoms? But we also have to think about what was the initial incident, because clearly the initial incident is going to affect the initial ATQ scores and whatnot. Some other key outcomes are really, Stacey mentioned that the partnership is the intervention. So we want to take a look at collaboration and make sure that all contacts did occur with both the clinician and officer present. On their outcome form, there's an entire subsection on collaboration and how it occurred. So it's one thing we want to look at, as well as engagement. Were the team that responded able to successfully connect with the family? And that connection looks a little bit different for each family. So there are a number of variables and factors there. But then also if an assessment was done and if a referral was made. So essentially what we plan to do in this quantitative evaluation is to connect all the different data that we have, link it through the family ID number, and then start running some of these analyses. But that does conclude the formal presentation that we have. So I'm not sure if we have any questions in the chat at this point, but it definitely is a great time. If you do have any questions for Stacey or I to let us know.
Yeah, thank you both, Stacey and Travis. That was a really wonderful presentation. I think it was kind of a nice balance of that very frontline in the moment work that goes on every day, like you said, 24/7. But then also important is that behind the scenes evaluation to make sure that is is this work actually making an impact, and how big of an impact is it making, and making sure that our processes are all set up to have the greatest impact possible. So thank you again, both, so much for that wonderful presentation. As Travis alluded to, we are preparing to open the session for questions. I think Michael, you've seen, has dropped the link to the Qualtrics survey in the chat. Take a minute or two to complete that anonymous survey to help us guide these sessions and make sure that they continue to be meaningful and informative. For those of you that are requesting any CHES or social work credits, of course, it will take you to a different, that survey will take you to a different section where you will have to provide your name and contact information so that we can get the appropriate credits to the appropriate people. But again, go ahead and click on that link, give us your feedback. And I think Michael has a quick comment to make, and I will start moderating the questions as they come in.
Yeah, we only have a few minutes, about 7 minutes left for questions. So please, if you have questions or comments, please drop them into the chat or let us know, and you can unmute and ask your question orally if you'd like. Then we'll leave a minute or so for the speakers to give kind of a wrap-up comment before we do our closing section. And again, I've placed the survey link in the chat.
So it looks like the first question I see in here is about the quantitative analysis. Are the outcomes all short-term, and are you looking for any longer-term outcomes, like 1 year post-event, for example?
Yeah, so currently we are looking only at short-term outcomes. We're essentially using administrative data that is available right now with the agency. But Stacey and I, and AFI as well, we are continuously exploring different funding opportunities that might enable us to do a longer term outcome, because essentially follow-up would be ideal. We just don't have the resources and capacity to do it right now.
So I actually have jotted down a couple of questions that came to mind with how heavy this work is. And thank you, Stacey, for kind of acknowledging that at the beginning, that this is heavy work. And it's sometimes hard to hear about the things that is the day and day work for your team. What does it look like for your team in terms of self-care and kind of processing the work that they do? I imagine it's a heavy load to carry, rather.
It is. I also want to acknowledge we're not alone in the work. We have partners who are going, out and are there first and are experiencing those same heavy things. I will say that for us, internally, we encourage staff to make really good use of time with supervisors. Our supervisors are people who have done the work themselves. We encourage, people to take the time that they need and to use that. But we also recently started sort of repurposed our all staff meeting and started using it not for administrative stuff. We get that done in a daily huddle together in the mornings, but we started using our our time all together in person for supportive purposes and really for connection with each other and fun too. So the staff have really responded well to the effort, and I wish we thought of it years ago, but it's been really good. The other piece that I think is critical is our clinicians work with officers every day who have done that same work, and there's a lot of mutual support that happens there. I don't want to downplay the experiences of other mental health professionals in the community and vicarious trauma. This this type of experience, I think we've coined the phrase professional trauma exposure because it's a little bit different, being there in the midst of the incident and in the midst of the suffering of other human beings, to be quite honest. I think the fact that we're there to help is very protective, and that's a big deal, and we acknowledge that regularly for our team. But I think the support comes internally and thankfully also externally from our police partners as well.
It certainly sounds like it takes a special type of person to do this work on all sides. In the beginning of your presentation, when you just talked about the growth of the community and the changing demographics, can you talk a little bit about situations where maybe there might be language or other cultural barriers, and how either on the CMPD side or on our side, we can best serve those families when there might be some communication barriers?
Yeah, we're really lucky. We have an out of 17 clinicians right now, we have 4 who are bilingual, bicultural, and that helps us respond really well to our Spanish-speaking families. But the question then is, okay, well, what about everybody else? We onboarded with that great app that a lot of our public health departments received recently. So all of our clinicians have access on their public health cell phones to an app that provides live access, almost like FaceTime, with an interpreter who, we have access to a lot of various languages, and that has been helpful. It's not as good, obviously, as having someone on staff who could speak every possible language, but it's a challenge. I mean, some parts of Charlotte are very, very diverse, have maybe a larger refugee population, for example, and the landscape is constantly changing, and we try and keep up. CMPD has an incentive program for officers who speak a variety of languages, and we thankfully have access to sometimes officers who are a good match for a family, linguistically or culturally, but not always. Yeah.
I'm sure it's always going to be a challenge that all of us that work in this field face, but it sounds like you've got some tools that you can keep handy to address in the moment.
Yeah.
Doesn't look like there are any other questions in the chat related to the presentations. And I guess I'll ask one more question of y'all, and that is, again, as you showed those numbers going up and up and up, how well are we able to meet this changing demand?
I will say over the years, as we've grown, we have been, like I said before, so lucky that as we were, we grew on the county side with staffing. We had, equally eager partners on the police side. We have had to create, just processes that are needed for a larger agency, so to speak, or a larger program as we grew, screening, triage kinds of pieces within our intake process, different levels of service based on the kind of events or incident referred. We have a whole group of families that may get family consultation versus a clinician officer team if the incident was not specifically acute trauma, for example. I talked about that, that chronic runaway piece, or some of the others where there's definitely a concern and definitely a need, and we want to address that. But, we're reserving this particular response and resource for a certain type of referral, if that makes sense.
That makes sense. Thank you. Well,
and Carrie, I want to do one other thing. I just want to throw out a commercial plug / thank you, if you will, to AFI, because a while back, several years back, Mike Doolin came in and did a presentation in a middle managers meeting, and I was just so incredibly excited, and I thought, I can't let him leave without going up and giving him my card and telling him I want to talk to him more, because we had been so desperate for a successful look at at our measures, at our outcomes, at the work that we do, and to have him get as excited about the idea as we were, and then to have AFI commit the resources that they have, and to have Dr. Hales from UNCC able to do a deep dive into the way that we're serving the community, and really help us look at it the way that I think it deserves to be looked at. I cannot thank AFI enough, and I would recommend anyone on the call who is on the fence about doing something like this to jump in. It's been a phenomenal experience.
I think that embodies sort of the whole intent of what AFI was created to do. So I'm sure they appreciate that plug. We are going to have to close out the question time. I think that some of our panelists, the panelists might be able to stay on the line after the meeting officially closes out if there's any kind of lingering questions. There is a comment I see in the chat now about, is there any article or report from the qualitative analysis that's available? So if that's something, Travis, that you're able to share either with us and we can send it out to the group, or get that person's contact information, we can do that. So Michael, I will turn it over to you briefly.
Thank you, Carrie, and thank you, Stacey, for those kind words about the role AFI has played in your work. We really appreciate that. I've reposted the link to the Qualtrics survey. That'll be available for the next week or so. It'll also be available along with the recording on our AFI Innovations website sometime, hopefully late next week, to have you have access to that. So if you need Ches or ECHE or social work contact hours, please make sure you complete the survey.